Welcome everyone to the webinar, The Second Wave. My name is David Pantaloni. I'm a curator at Ingenium, Canada's Museums of Science and Innovation. Ce webinaire est en anglais, mais il sera enregistré et traduit en français. Thanks to Ingenium for hosting this webinar, and for my colleagues Brian Regg and Anna Adamick for working hard behind the scenes to make this work. Thanks to our supporters, the Royal Society of Canada. One of our panelists, Esyllt, is on the COVID task force for them. And they have really good blogs related to COVID if you go to their website. The Canadian Society for the History of Medicine is a sponsor, and both two of our panelists, Chris and Esyllt, are part of that society, and they also have a really good webinar series on pandemic histories. And the University of Ottawa. Doug and I are both profs at the University of Ottawa, and of course they're doing, among other things, frontline research right now on COVID. And I want to say a special thank you to Seniors Without Walls. They run a really innovative program where room-bound seniors can listen to live presentations by telephone. 2 months ago, I presented on the Spanish flu to this community. Their questions were direct and challenging on both scientific and historical levels, and of course mixed in with deep concern about COVID. The idea for this panel came from that discussion. Seniors gave us their best over the years. We owe them our best in return. So I really thank our panelists today for stepping up to that challenge. Our panelists today, if our panelists could please introduce themselves. Esyllt, starting with you.
Sure. I'm Esyllt Jones. I teach in history at the University of Manitoba, and I'm also a part-time member of community health sciences there. I've been writing about influenza, the history of the global pandemic of influenza, for quite a long time. I did my PhD on it, which eventually was published as a book called Influenza in 1918, Disease, Death, and Struggle in Winnipeg. Aside from that, I also do research on the history of socialized medicine in Canada.
Chris, could you introduce yourself?
Sure, pardon the phone in the background. I'm Christopher Rutty. I'm a medical historian in private practice. I guess I've been for about 20-something years. Although I have an adjunct appointment at the University of Toronto's Atlanta School of Public Health, where I've been integrating history into the school as best I can. Doing my PhD in the history of polio in Canada at the University of Toronto with Professor Michael Bliss. And that work evolved into lots of different projects on history of vaccines in Canada, on history of insulin. I'm doing a lot on the 100th anniversary of insulin as well. I'm sort of resident historian at Sanofi Pasteur, Canada, which is the kind of current legacy of Connaught Laboratories, which is part of U of T from 1914 to 72. And behind me is a wall from the Heritage Room at Sanofi Pasteur's Toronto site. So, so I've been involved with a number of things with COVID and history of polio in particular, relating it to the current situation. And so that's probably enough for now.
Thanks, Chris. And we're all going to be hearing a lot more from Chris next year with the anniversary of insulin coming up, the discovery of insulin in 1921. Doug, introduce yourself, please.
I'm Doug Manuel. I'm a senior scientist at the Ottawa Hospital, and I'm a professor at in the Department of Family Medicine and School of Epidemiology and Public Health at University of Ottawa. I do mostly research. I do family practice, and I'm a public health specialist. So mostly research in public health and healthcare.
All right, and happily for us, Doug has a keen interest in history of medicine. So we're going to start with a panel discussion today, followed by questions from the audience. We will not be able to answer all the questions, but we're really looking forward to them. I always find the question sessions sometimes the best questions come out of that, as they did with the Seniors Without Walls. So we're looking forward to your questions. We'll try our best. But Doug, I want to start with a big question for you. Why the question mark after second wave? We had a big back and forth about this, and we put a question mark after second wave. And a few little related questions. If you could define it, the second wave, and tell us what you're seeing this fall and the primary challenge moving forward. And if you forget some of those questions, I'll remind you. Thanks.
Okay. Well, I think there's two reasons for the question mark. there's probably many reasons, but the first one is probably what is a second wave, like the definition. And I think, a lot of epidemiologists and public health specialists don't use the term a lot. So that's maybe one reason we don't really have a good definition for it. Maybe I'll give a definition, and that we can try using. If people don't like it, the panelists don't like it, we can debate that too. But I'll give a definition of a second wave as a resurgence that causes sort of COVID spreading uncontrollably in the community. So like this, it's just not an isolated outbreak at a nail salon, but it's then spreads out, and has this potential, sort of rapid increase. So I would maybe put a caveat in there that it said that it causes real health effects. So in sense of hospitalization or death. And I think it's good to put that sort of human health part in, because it will change our discussion a bit. So maybe that's how I'll define it for this panel at least. But there's no good definition, nor clear definition. The other question mark is that, I think from our perspective as scientists or public health experts or modelers or infectious disease experts, there's not a lot of consensus whether we'll see a resurgence or a second wave coming forward. And, I think there's some people will say it's definitely going to happen or very likely going to happen. And a lot of people say, it really depends. And so this huge range. And when I come at this, I say it depends a lot on sociology and history. So that's what I'm really interested in this panel. Dave, does that answer? You had one more question,
yeah.
I think.
Yeah, well, and within it depends, what is the primary challenge that you see right now moving forward? If I could pin you down, that probably changes every few hours or every day for you, but
well, I think let me just first answering that, like, where are we today? And so if you look at Canada, have we had a first wave in the East Coast? We haven't had a case of COVID in Newfoundland or PEI in over a month. And, we think of New Zealand as a success story, or Australia, but I say our islands have the same signature. A few cases, not really sustained outbreak in many of the parts of the East Coast, and then it died down or controlled very quickly. We have, like, say, Saskatchewan, where there's now, like, if you look at the graph, it looks like there's 3 peaks. And so maybe we've had, 3 weeks. I think there's a general consensus that we're still in the early part of the outbreak. And if we slow down anything, then we'd have this explosive growth that you're seeing, like in southern Florida. So southern Florida was going down, and then it's gone up higher. The United States, there's more cases now than there has been in the past. So very early on, and just to refresh ourselves too, that we've seen a lot of cases in the cities, Montreal and Toronto especially, and we've seen this sort of pattern of these very intense focal areas, northern Alberta with the meat packers, currently migrant workers in British Columbia or Ontario, and then we'll never forget the long-term care. So very high levels of transmission and death in long-term care. So that's where we are. Moving the fall, I think the most of the projections are looking pretty good. They're coming down. And then the question is, there's going to continue to be these focused outbreaks. We saw this week, nail salon. In Ontario, we saw cases in northern New Brunswick. We see migrant workers. So we're going to have these local, they're going to be almost impossible to stop, these local outbreaks. And the question is, in everyone's mind, is this going to then spread out? Is the ability to transmit is there, and will it happen? Will we be open enough that COVID's going to start spreading before we know what's going on, before we can control it? And will that cause this sort of resurgence or second wave? So I'll stop there.
I think some of the historical details are going to be instructive here about where these pockets are. And so my follow-up question to Esyllt is, so why the question mark after second wave for you? You felt the same way, Esyllt. And then maybe give us some details of where you've studied closely in Winnipeg. That would be great to kind of give some historical texture and context to some of the problems that Doug is laying out there. Oh, Esyllt, you're on mute.
I'm on mute.
Yeah.
Sorry. when historians of influenza are looking at that experience, they're able to look at a retrospective way. So what you see with the 1918, 19, or into 1920 outbreaks is this general pattern of three waves. So a wave in March of spring of 1918, the fall wave of 1918, and then a spring wave in 1919. And then in some places like Quebec, which didn't get the third wave in the spring of 1919, theirs came in 1920. So that's a generalization. But the issue for me is that when we don't, of course, know completely yet what's happened with COVID. So it's quite possible that, in a few years' time, when we're looking back, we may discover, or that the best way of thinking of it was that there was a small first wave that was largely negligible and not very visible to the public, which is what happened with the flu. The large wave with flu, the largest, was the second wave in the fall. And the third wave was, again, smaller. So it could be that we end up seeing a similar pattern with COVID, that we had an earlier outbreak that has been not as visible to us yet until we take a closer look. Then the fall wave, the second wave, is the wave we're living through now globally, which appears to be quite large now and becoming really, really very big, with 500,000 deaths so far. And then what happens after that, we don't know. Or it might not be like that at all. It could be that we will have a large wave and then another large wave. But if that were to happen, that would be very different from what happened in 1918 to 1920. So there was one massive wave and other waves that were more localized, smaller, not everyone got them. So the idea of the wave is useful in some ways and not as useful in other ways. And I think too, it's important to realize that there are big holes even now after 100 years in our knowledge of what happened, particularly outside major urban centers and in Indigenous communities, where we do know that some Indigenous communities don't fit that chronology of the three waves. Some of them had influenza outbreaks at different times, including some that were quite a long period after influenza had largely died off in major urban centers. So we need always to be aware of the limits of it. But for me, this feels like it, if I were to have a parallel, like the second wave of influenza. And if that were to be true and the patterns are the same, then I wouldn't expect another large wave. But every day we are having more and more sort of difficulty figuring out whether we're through the first wave or not. So yeah, it's all an interesting bunch of problems that leave a lot of questions unanswered when we're seeking to try to find parallels between what happened in that pandemic and what's happening today.
And I've raised it with you guys. I think with that uncertainty around the wave metaphor, I wonder if we're trapped in it, and it might be, the history might be creating problems where they don't exist. I'm not sure with that uncertainty around the metaphor. Is that a problem, Doug?
Yeah, I think so. Esyllt, even the way that you're talking, it sort of feels a little bit deterministic, the way you're saying, like we are, we're going to see a second wave. And I think from our perspective, it's not destined at all. Well, it depends on how we respond to it as a community. There's tremendous potential, but we've already, when we flattened it, it's because we controlled it. And we controlled it largely with physical distancing. We can do that again. Like we've shown that we've been able to do it, so that can we, the question is, can we open up and still disrupt transmission? And this is the lessons I need to learn from the past. What happened to, what did it just go, was it uncontrolled and we had if we can have waves from uncontrolled, or where in the past we've never tried to control an infectious disease like this in our lives. and how did those waves happen in the past because they controlled it, or did it just go through the communities and then have another resurgence, like transmit, come down, still some susceptibles left, and it resurges again. We brought it down now, and we can stop it from coming in the future.
Well, we're going to get back to Winnipeg, but I want to go to Toronto, which has been an epicenter here. In the now with COVID. And Chris, if you could give us some, as the description of what happened in Toronto and what measures were taken, what worked. Just give us a little flavor for that historically. That would be great.
Okay, before I do that, I just want to make one point. I mean, we're talking a lot about comparing COVID with flu, which is problematic in and of itself. There's a lot of differences. And also in terms of waves, we only tend to focus on flu waves. I mean, and we focus on 1918, the waves then, but there's also a pandemic in 1957, 58, followed a similar pattern, and in 1968, and in 2009. And there's defined waves of different times in different places and for different reasons. And most of the pandemics of flu were driven by the young, especially 1918 were military soldiers coming back from the war, a lot of factors like that. And also in the later ones, you get the impact of schools. You close schools and kids go back to school. A lot of those second waves are generated by kids because flu's much, they're very vulnerable and very good at spreading it. So we have to keep that in mind, that we have to be careful how we equate COVID with flu, just on a basic level and trying to talk about waves. So, but anyway, to answer your question, 1918 in Toronto was actually, Toronto did pretty good. Just looking back at the situation compared to other similar cities, the death rate or the percentage of deaths per population, I guess in general, was lower. A lot of that's to do with the work of the Toronto Medical Officer of Health, Charles Hastings, who served from 1910 to 1929, and he was a real progressive public health man. He was at one point was the president of the American Public Health Association, and during the pandemic he was in that position, and he was well connected with the states. He actually went down to Boston early October, and the Northeast, where the second wave, as it were, hit hardest at first, New York City and Boston and Washington. And he consulted with a number of leaders there at the time. And the whole predication of his approach was based on education, public health education, and informing people. He was not a big believer in imposing mask wearing, for example. There's a lot of tensions around quarantine and isolation. And in Toronto at that time, as the second wave kind of kicked off very dramatically, it was realized you couldn't do much about it. You couldn't impose quarantine. And also flu wasn't notifiable. It wasn't a notifiable disease. So there was no real basis of information to work with beyond sort of death rates after the fact. And so the response was based on, so the social distancing idea was more of that. And a real kind of clash as well between kind of a provincial perspective, resistance to closing things down. I mean, there was a lot of desire from some people to close schools and close movie theaters and all that kind of stuff. And from a provincial point of view, they didn't think that was good, necessarily useful, unless it's in a small town maybe, but in a big city, what happens to the kids if you're closing schools? They're running around all over the place. I mean, it's not really that useful ultimately. And so, although the Hastings and others in various cities did do that anyway, but this was very hard to resist closing things down anyway. There was a lot of, the response was based a lot around a lot of volunteerism, the SOS, sort of Sisters of Service, I think the term was, enlisting a lot of public health nurses and volunteer women, because there was a real shortage of men because of the war, because this was before the war even ended. And there's a lot of medical people there was a real shortage of doctors and public health people in general because of the war. So there's a real strong role of women in coordinating information and working with kids as well, scout groups, and really driving the whole idea of information to the public. This was before, obviously, the internet and radio didn't exist, but they were efforts to send out cards to families and have like Boy Scouts running around town, handing out cards, questionnaire cards of how you're doing, go back the day later, pick them back up and go through them. So there was a real pioneering spirit in that sense. It built a lot on the war experience. And that's a big part of the whole 1918 experience. It's very much driven by the war posture. Everybody kind of real tuned into that whole thing. And even in subsequent waves, when you talk about 57 and 68, the military element and distributing the virus around the world is very much a big part of how it got around through shipping or sort of land-based, and then later on you get into the role of airplanes and air traffic. And 2009 was very much driven by international travel and commerce and the globalization. So all these sort of elements are what drive second waves or other waves, which is what's very much at play with COVID. Although international travel has been really ramped down, but still it's a big part of how the international travel system is important.
Chris, I'm going to ask Doug in more detail this question, but you just listed so many public health initiatives that are incredibly progressive, and that's what's shocking when you look at the news clippings from that time. I think it's shocking for people in the present because we think we're so great, and then you look at these incredible initiatives back then. At the same time, my question is, like, what actually are we doing that is maybe more advanced than if at all? It actually, when you look back at it, it's actually a little shocking. And then I want to go to Doug and ask kind of the same question.
Well, the 1918 situation was sort of classic in many ways because there wasn't, well, to try a vaccine, but we'll get to that in a minute, but there really wasn't any real active treatment or intervention you could really do other than non-medical, non-pharmaceutical interventions in the masks and the social distancing. And that's a very basic thing in public health. And the problem is we haven't had to deal with this very often since that time. I mean, even I mentioned the other pandemics, but they were relatively modest. And flu is a known thing. So the thing about COVID is we don't really know much about it. I mean, in 1918, we didn't know there was a virus involved with the flu. But still, they recognized it as a respiratory infection they could see. And so that the whole response was very similar to what we're doing with COVID, because in the absence of other interventions, when you know you have a respiratory disease, that's what you do. And it seems to, and it works.
So up until now, we've kind of been in 1918, and now I think things are changing.
If I could just jump in for a second. I mean, I think the one biggest difference is the resources that are being committed to allowing people to stay at home.
Yeah.
Which didn't happen in 1918-19. People still went to work. Many of them were working, of course, in unsafe workplaces. So places that were poorly ventilated and so on. So the economic equation was very different. And I think that's a key piece to understanding some of the differences now, because it drives ability for people to shelter at home, or at least some people to, not everyone. But it also creates a new dynamic, also creates a new set of challenges for public health officers. In 1918-19, there was no sick benefits, no Medicare, no income support. So.
Well, and another key difference between flu and COVID is just the role of the subclinical, or whether it's subclinical, or at least asymptomatic or pre-symptomatic spread. And that's really what's driving the situation here, more so than I think it happened with flu. Flu is a much shorter incubation period. And so the COVID can spread much more widely and rapidly without realizing it, which is really what's driving the situation in the States, or the whole world really. And we're realizing that it had been spreading before December, even in Europe. And so, testing sewage and things like that, we're getting a sense that it's been around a lot longer than we think. And so it's got further afield than we assumed it did originally. And that's why we're in the situation we're in, and why it's so difficult to get a handle on it, really.
I want to go put the scientist on a hot seat for a minute. So I think I've got a little list here just from reading the paper every day. The medical community's learned so much over the past few months. It's been exponential, the amount learned, the public health successes. I love these little positive stories read in the morning, little tricks such as using steroids for some of the most serious cases, gives us all hope. learning much more about the complexities of ventilators. Doug and I have had a lot of conversations about that. Learning more about transmission, the nature and behavior of the virus, tons of data coming in from around the world. It's incredible what's been going on every day. But so Doug, how is this changing your modeling going into the fall? And what surprised you as this is unfolded? What surprised you the most?
Well, I think there's a few surprises, as the story's sort of been written. From the virus perspective, there's three distinguishing features, I think, that are really affecting the models. One is the pre-symptomatic spread or the asymptomatic spread. And now that we've recognized that, it's created a really large challenge. Second is the speed. We've seen these curves, these doubling times of 2 days, 3 days, 4 days. It's just, and this, who thought that we'd all be learning to read log curves again after high school, or that I would be presenting log curves and people would be understanding them. I think the third major challenge is that it's sort of a virus with two heads. For a lot of people, it's quite mild. Younger people, it's quite mild. And you can kind of think, oh, maybe you can take your chances. But on the other side, it's a very deadly disease. And so that's a challenge because it kind of affects people, people differently. And they all go through together. So now when we have asymptomatic but rapid spread, it means you can have 3, 4, you can have these chains. And because it's mild, it may be going through, and it's not only and it pops its head up. By the time it's popped its head up, it's spread all over the place. And kind of have that feeling of spreading rapidly but silently. So that poses a major challenge for control. And you see it in these models. You see it in these models where they take off. And we're not that far below where it can take off. This basic reproduction number, again, like I can say these terms and many of the audience will know them, but we're below 1, but not much. So as we open up and we reduce our control, it's going to have that increased transmissibility. And can we open up and move around, but still keep that physical distancing so infections doesn't spread? That's what we know. And then the control part is really interesting because we learned that we can control it. We learned that from Wuhan, and then we sort of said, okay, can we do what Wuhan did in other parts of the world, but maybe with a different sort of cultural flavor? Peace, order, and good government as opposed to sort of a central sort of process. And we did show we could done that. And now moving forward, the uncertainty is, can we find that balance? Can we disrupt transmission, but still get back to work, get back to school, and have some of our humanity back? Can we have our arts back? Can we get, how close can we get together?
It's interesting because when we started there, you were talking about fairly technical medical things, and then when in your language, when you become more uncertain, you can see you gravitating towards social questions, cultural questions, these broader uncertainties, and I think that's where your hunger for historical knowledge comes from, because it is instructive in that way.
Yeah, I say that this isn't a question of biology and epidemiology. We know enough, and we know enough how it's spread, and we know enough how it's controlled in broad strokes. For me, the questions are more history, sociology, political science, economics. Have we shown that we can sustain these, or can, if with increased social support, will we be able to break up transmission? And that's my questions to the other panelists, and that's why I'm here today.
Well, so I want to shift to Esyllt again on that exact question, because what I love about Esyltt's work in Winnipeg and especially is that her work has actually been very relevant in the past month about the connection between pandemics and social unrest, medicine and resistance. And you have a beautiful phrase, Esyllt, the Rubik's Cube of social unrest and pandemic disease. And actually the cube is resistance, medicine, social unrest, and then pandemics. It is a Rubik's Cube. So I'd love to hear you talk about that because your work is resonating right now, and I think explaining so much for us. It'd be great to hear from you on that.
Yeah, I think Doug is raising issues there about what sort of social responses we could mount to do as well as we can possibly do given the science that we have. And, you know, the complications of the puzzle come, I think, in part for us, first of all, because we live in the society that we lived in before the first day that we started the lockdown. And the inequities in that society become heightened, but the fact that they already existed is where the story begins. So in my work on Winnipeg, I've tried to trace, I was motivated really first and foremost by the question of trying to figure out what it was that working class and ethnic community members wanted in terms of healthcare, and where the healthcare system was failing them. And then influenza became a way to talk about that. And you had a society then, a rapidly growing city in a, built on Indigenous dispossession, massive in waves of migration before the outbreak of the war, very serious infrastructure gaps, social infrastructure, health infrastructure. And those conditions were not ones that you could wish away when you have a pandemic outbreak. So I think today when we're looking at the relationship between COVID and, say, the current movement for racial justice and against police brutality, this is an issue that has been so long there and really structures people's daily lives and experience in a very powerful way. And then when you twin it with an outbreak, which it's itself, of course, not equally felt by everyone. And that was the case in 1918-19 also, where people who were living in poor areas, people who were in newcomer families had higher death rates. Those things come together, and then you have potentially a very serious challenge going forward with maintaining trust and good communication and the availability of positive and useful public health messaging. So public health itself, unfortunately, needs to kind of grapple with these existing realities and inequalities in a way that I think can be difficult. Not impossible, but difficult. So there are, I mean, historically, one of the close relationships between particularly violent unrest and disease outbreaks, whether they're epidemic or pandemic, is around the question of coercion and consent. So in societies where you saw a higher degree of coercive public health measures, involuntary sequestering of the ill, for example, or the burning or destruction of people's property, which were common public health practices, particularly in the colonial world, say in the late 19th and early 20th centuries, you often had quite violent forms of resistance emerging. If you had societies where there was a greater level of consent, the resistance might take different forms. And that one of the stories, I think, of the development of liberal democracy is that the relationship between consent and coercion in public health, because one of the major challenges of governments in the period of the Industrial Revolution, if we can use that as a shorthand, was trying to figure out how to deal with the kind of onslaught of infectious diseases that were affecting everyone's lives. So different societies have dealt with those questions differently. And for us, we have a strong, of course, history of developing consent rather than coercive measures. And Chris referred to this in his discussion of Hastings. Already by the early 20th century, that was in place. A very strong awareness of how not helpful it was to use coercive measures. So we're building on that base, but then the challenge becomes, how do we deal with the inequities of the pandemic, which raise slightly different issues. And I don't think there's any accident that these issues come together over questions of brutality. And like, again, it is that Rubik's Cube, right? There's not a straight line from A to B. There's the way these factors interlock, and they can be shifted, of course. I agree with Doug that we can make decisions that can shift those dynamics in a positive way.
And I love, just a quick comment, I love when you equate every decision, there's a burden that falls on and so the Dougs of the world have to think about those no matter how well intentioned and modeled the decisions are, there's a burden that falls on certain segments of society in some way.
And I think I don't mean this to sound critical, but I think that we are generally, as a society, slow to recognize how much inequity shapes these pieces. And so, when we talk about long-term care, which is, I'm not exactly sure how the inequity piece comes into long-term care, but I do know how it comes into the people who work there. So we could have seen that coming, right? And in places like BC, they did a better job of that by trying to create a scenario where workers were not being exploited by, being sent from workplace to workplace by a multiplicity of employers. But all of those is kind of a tough job for public health people who have to not just deal with what's in front of them today, but the social structure that they're building on, I guess, or that they have to cope with.
I want to be mindful. In about 5 minutes, we're going to go to Q&A. So, but I still have a few burning questions. So within the public health, within the all the different tools at the disposal of public health, is this idea of vaccines. And I wanted to ask Doug. A colleague of mine said recently, matter-of-factly, well, when the vaccine comes, as if it was going to be arriving on a chariot at December 21st, 2020. And I wanted to get you to respond to that optimism, and what do you make of the vaccine discourse as we move into the fall?
Well, I think maybe partly the optimism is lack of other options. When you look at our exit strategies, they're not that great. So vaccine is the best way to get out of this. So maybe forced optimism but I think there is reason to be optimistic as well. That one is that we've made vaccines before, and that this is we know what a virus is now. We know what an RNA virus is, and we can successfully make viruses. And I think Chris would know better, but there's about 100 initiatives worldwide right now, and the innovation around this is incredible as well. So we can now make a vaccine for a virus, but you don't even have to have the virus. You just need the genetic code, and that genetic code was sequenced and distributed worldwide through an open science within weeks. And so the pace and the acceleration and the innovation, building on this experience of our history from Pasteur, or I don't even know when the first vaccines are, Dave, but yeah, but I think that there's that this is extremely effective, and there's going to be all sorts of uncertainties as it comes out. When will it come out is a big uncertainty, and how effective, and will it be safe? These are going to be kind of questions, but for us as public health, I think that we see a lot of signs for optimism. Because we know that they're very effective, and that we've had some experience with these before, and that experience has shown sort of this remarkable acceleration. So maybe I'm optimistic, maybe an optimistic guy, but yeah.
Well, and I'll get a little quip in that, and then if we do get the miracle vaccine, we have the example of measles where we have it and some people aren't using it. But let's not go there. Chris, I want to show something on the screen, and again, sorry, mindful that we're getting to Q&A here, but I just want you to unpackage this a little bit for us.
Okay.
Anyway, while I bring it up, I want let's see. Chris, if you could, Chris was the one who discovered this 1918. Is it on the screen there, guys?
No, you just have the your Finder thing again.
Oh, I'm sorry. Okay.
Or it's opening up, I think.
It might be opening up, but while he's doing that.
Let me just describe that, Chris, in our museum, we have a 1918 influenza vaccine that Chris actually found, because I wasn't aware that it was in there, or the significance of it. And Chris, just tell us a bit about that, because that's an amazing part of Canadian history, and why it would be a little relevant to today.
Well, I mean, a big part of flu pandemics particularly is the whole issue of vaccine potentially. And this goes way back to 1918 even, before they even knew it was a virus that was causing a disease. But there was a sense that a bacteria, influenza bacteria, was the cause, and a real, at that time, was a real kind of fervent towards vaccines, trying to do something quickly. And bacterial vaccines there were various types of them around. Not few did anything really. It was not the best time for vaccines really, but they tried. But at the time, there was the idea that the flu vaccine, or flu was being caused by a bacteria, and so a real effort, not just here in Toronto, the nouvelle there's from Connaught Labs, and was part of U of T, and there was a major effort undertaken based at Connaught, kind of in collaboration with provincial laboratories, to build on some experience that was happening in Boston. I mentioned Hastings visiting down in Boston early in October. I think he took assistant director of Connaught down with him, and they brought back some samples of what they thought was the causative agent of the flu at the time. And a number of people in Boston and New York, even out in Winnipeg even, and Kingston and Toronto, fervently tried to prepare a vaccine, basically culture the bacteria and kill it, and in hopes of it might be effective in some level. And it wasn't really harmful, but it was really indicative of a reliance on vaccine, trying to do something with what the technology they had available. And that's kind of a theme that's current, or a part of the story of vaccines, is adapting and utilizing the available understanding, the available knowledge and technology to make a vaccine. And the same thing applied with polio later on, or even today with COVID. We're all kind of scrambling around trying to figure out how to make a vaccine in the hopes that it will solve our problems. And it's often much more complicated than that. COVID's sort of showing it's not a simple thing. Polio vaccine, though it took a long time to get to that point to have it, ended up being a fairly straightforward process to prepare an activated polio vaccine. And we've essentially eradicated polio through two types of polio vaccines. And it's a straightforward thing. COVID is much more complicated. And the situation in 1918 was such that, there's just a lot of hopes placed in something like that based on the available knowledge and technology. And flu kind of does that a lot. We went through this in 2009 with the H1n1 pandemic. Canada was actually one of the few countries that spent a lot of effort and money on having a vaccine available, and available for free nationally. There's also the undercutting theme of we've had a flu vaccine, or a seasonal vaccine, and the odd pandemic, but there's still half the people in the world, or in Canada at least, don't take it. I mean, it's available for free, seasonal vaccine every fall, and how many actually take it, right? And so that raises the question of COVID. We're going to have a vaccine at some point, hopefully. How many are going to actually take it, right? Apart from the whole anti-vaccine stuff, just in general, just in actually deciding to even take it, in that sense. So,
well, I want to before we kind of go to Q&A, I want to talk to maybe about this ambivalence idea. Talk to Esyllt. She's raised the issue of forgetting and pandemics, and how quickly the flu pandemic, was omitted from the public discourse, and so I'd like you to talk about that for a second, Esyllt.
Well, for me, it relates to this question of resistance and the kinds of conversations we're having in Canada right now about, we don't want to go back to normal. We want to go to something better after it's over. Mm-hmm. And over years of thinking through how memory has worked in the case of influenza, now I think, this phrase, the forgotten pandemic, which was the title of Alfred Crosby, an American historian, the second title of his book on flu in the US. The first title was called Epidemic in Peace. But in the context of threats of infectious disease outbreaks, the title became The Forgotten Pandemic. It's an interesting shift. So the narrative of forgetting is very powerful around influenza's history. And my question now has always is who's forgotten? So forgotten by whom? And I think in terms of public history, the flu was sort of superseded by the history of the First World War. But David, you yourself have a family story about flu, right? Mm-hmm. And in the many talks I've given about flu, that's always the case. And so we know that families remembered, family members remembered, but at a public level, and I think partly because of 1919 was a year of deep labor unrest across Canada, not just in Winnipeg. There are reasons to want to sort of suppress some of that kind of unsettled nature, the way in which social inequality becomes challenged. There's a temptation to sort of crush those discussions as quickly as possible or to move on, and a big pressure on normalization. So we just want to go back to normal. So that tension is always there. And the pain, I think, that narrative of the forgotten pandemic has caused people is very real, and literary scholars and historians now just sort of started to talk about that, about what it was like to live through that event and yet have it kind of, sort of glossed over. It's an interesting question.
I love how your work is so relevant to today. You mentioned my Sicilian grandmother's first husband died in the Spanish flu. Mm-hmm. Now, what about this forgetting today? How does that worry you?
Well, we don't have to go back 100 years, it seems, to forget. Like, have we forgotten Northern Italy? Have we forgotten New York as we open up? So I think Esyllt said it, like I don't know if it's we forget, but there's a lot of pressures, right? Like to gain back our humanity and to have close connections. We are a very social species. We need each other to survive, both physically, like we don't now forage our own food. We work together. Where someone may make food, and I help if you get sick, and so our society is intertwined, but we're also very social creatures. So there's this tremendous force for us to get together, but it's only been a few weeks that we've seen, or we've seen this devastation go around the world, and when you see that, and how do you cross that with now people's activities sometimes. So I think this is again our challenge of science and sociology kind of all together.
Well, I have a great question from UBC, and Guy writes to us. I'd like to argue that for the Spanish flu, waves are actually caused by the on and off confined society, open society approach that was used in deciding NPIs. I'm a control engineer, and in my field, it is well known that on-off control leads to oscillatory behavior. Today, with a control engineering approach, it is possible to avoid this type of behavior. We indeed can show that careful feedback-driven reopening, with that, we can control the pandemic, keeping the rate of infection fairly constant and a level manageable for our healthcare system. What does the panel think of this approach? Doug?
Well, I think it's kind of what we've been trying to do in some ways. I wouldn't say it has been on off, like, stage 1, stage 2, stage 3. I think the thinking behind this is that is this sort of control mechanism. I think whenever I talk as well, or public health talks, it's like, be prepared for a rollback. Like, we're going to see how it goes. And as we open up, the pressure of transmission is going to increase. I think one of the challenges we have is and I think it was David in UBC, as at operations, he knows, like, you have control on one side and you have the outcome on the other side. And for the control measures, it's 2, 3, 4 weeks apart, where if we open up, it will take a while for COVID to pick up. That's the science. I think there's a whole history and sociology of that. So I'd pass that over.
I can say something, I guess. I mean, this whole idea of control and that sort of mechanistic on-off situation may work in pipes and water control or something, but for an epidemic, especially this, as I mentioned before, just the particular characteristics of COVID and its subclinical asymptomatic phase, where it's spreading without people realizing it's spreading before they realize they're sick. That's basically negates that possibility of really being able to turn things off and on. I mean, there's other factors too. I mean, we have the advantage here in Canada. We've done better than the Americans. A big part of that is just our health system is much more a better foundation. So people don't have to think about the money to go to see the doctor. You know, that's not, there's fewer impediments if I feel sick for me to go to the doctor or to go to the hospital. Where the States, there's all kinds of impediments in the way of a lot of people, especially the underprivileged level or the people that are most vulnerable. They're second guessing themselves, they're staying at home, or they're living in multi-generational situations. So there's a lot of opportunities for spread apart from any kind of control levels. And so, I mean, and also with flu pandemics, the young aged kids or young adults tend to be the generators of the second waves of the pandemic's growth. And that's what's happened in 1918 and 57, 68. And that's what's happening right now in the States in many ways. So the source of what's happening is this opening up. And a lot of the 20 or 30-year-old people going to bars and getting out and trying to, you know, come out of the shutdowns and so forth and going right back to that. And they're the ones that are showing up now in hospitals. You know, and there's a shift to that population group. So the idea of trying to turn things off and on is very difficult to really have that work in a situation like we're in, I think.
We have a little bit of time left, but I wanted to shift to one of the questions from the seniors, because I thought it was so, I wrote down a bunch of questions from them, and one of them asked a very pressing question about the impact on men and women in 1918. And we're seeing that today too, these kind of gender issues, even with the uptake of domestic abuse and things like that. Esyllt, if you could comment on that or that question, I think that would be really interesting.
Well, you know, 1918-19 was even more deeply than our society in Canada is today, very gendered, of course. So there were both opportunities and heavy burdens placed on women because of that. So as Chris mentioned, a lot of volunteerism from women who were normally responsible for health and welfare and anything that went on within the private sphere of the home. And for the most part, those gender boundaries weren't really transgressed. So in 1918-19, very different from today, you did have people going out into homes of those infected to make sure that they had food, clean bedding, that they would be hydrated to provide basic care. Very few men did that, just a small number of men. My work talks a little bit about the long-term implications of that pandemic for Canadian society, and I have done some work on what happens to families when they lose either female or male heads of households or mothers or fathers. And of course, most women didn't work outside the home in that period, except for maybe early in their marriages if they were working class women. So because flu killed so many people in that age demographic, 20 to 40, there were a lot of widows and widowers with children. And the gender dynamics of that were very different because women, their number one problem going forward was how to support their family financially. For men, the number one issue moving forward was who was going to care for their kids. So you had very different long-term consequences for families depending on how their family was able to respond. Today in COVID, I mean, one of the things that worries me is the extent to which there are deep employment impacts for women because of the gendered nature of the service sector, for instance. So many more women are unemployed than there are men. And that, of course, is going to have different implications depending on the family setup. But it is one thing that public policy needs to pay attention to is how, you know, the gendered nature of the labor force affects women, and how job creation going forward should work to counteract that.
Thanks, Esyllt. I have just two more questions, and then we have to sign off. First of all, Guy from UBC said he wasn't arguing for an on-off, but for a more subtle feedback kind of system. Someone writes here, Chris alluded to this, just wondering about the impacts of media and social media on people's perceptions. We see what's happening in Italy, Brazil, the US almost in real time, whereas in 1918, these media weren't available. How might this availability of information and misinformation impact behavior? Thoughts?
Well, in 1918, the press played a very large role in all this. And I mentioned before how Hastings in particular was very big on information. And he was fighting against misinformation. There was a lot of quack cures and, you know, newspapers full of patent medicine, you know, remedies and so forth, which was rife at that time. And so there was a real constant tension between the right information from a public health perspective, based on what they knew, versus, you know, a lot of home remedies and all kinds of things like that. And that's, you know, it's a similar situation you could apply to today, you know, just different media, and the pace was different. But in those days, newspapers came out sometimes twice a day. You know, there was several newspapers in Toronto. Like now we have, you know, not one, two or three, if that. But in those days, there was multiple editions and multiple newspapers in multiple languages. And so, you know, for the size of Toronto at that time, or cities at that time, they had a lot of newspapers, a lot of media floating around. Not to mention distant personal exchanges and telegrams and things like that we kind of take for granted that we don't sort of think about now. You know, so it was a similar situation.
We're out of time. I really want to thank our panelists and the audience and all our supporters. There's one more pressing question. Great discussion, but what's going to happen this fall? And I'll leave that for Doug there. Doug, you're on mute.
What's going to happen this fall? What will happen is we'll be still living with COVID. It will be we're still going to be thinking about how to control outbreaks and whether it's going to be spreading. And we're going to be, I think, trying to weave that. Like I think at the beginning, you know, we had this huge lockdown, a very crude measure that we knew was going to have a lot of negative consequences, including inequalities. And so, you know, I think the federal government especially moved in with a lot of measures to try to reduce that. And now it's trying to learn from that. There's no perfect path between no health effects and every other effect. So there's no perfect path through this. So it's how can we weave a path through where we can control or stop the spread of disease and have our humanity and our economics and reduce social inequalities. And I think that's what we're going to be seeing over the next months. You know, can we get our schools back, and if so, how? And can we get our workforce back, or help people that are affected by that? And can we get our humanity back? So I think, you know, as you are, we're now doing webinars with the museum as opposed to being physically in the museum. So how can we still connect and learn from history and learn from science? So I think that that's what we're doing, and that's what we're going to be seeing over the next few months.
Thank you so much. Thanks, everyone. Thanks for our panelists for taking time, and for everyone listening. And hope everyone has a good day, and tune in to our next webinar. Thank you.